If you enjoy this content, please take a moment to rate and review it. Your feedback will greatly impact our ability to reach more people. Thank you.
Okay, welcome everyone to Health Further. We have the weekly roll-up show. Marcus has left the country. He is headed south. I'm not going to dox him right now, but he is moving his primary location. I think we'll have more from him in a couple of weeks. But we have a guest host today. So I'm excited to have Mitch Mudra, who's a friend of mine. I've invested in his company, Assort Health. Mitch, thanks for joining us.
It's an absolute pleasure, Vic. Thanks for having me.
As you know, we cover kind of the news on a bunch of fronts every week. We're going to go through the headlines. But before we do, I wanted just to sort of note really hard news story. It's not really a health story, but it's just a human story of the shooting, the mass shooting, right where you live there in Minneapolis. It probably has affected people you know. So I just really want to note there's a lot of people suffering right now. It's a bad story on all fronts, really. Mental health, safety, gun control, all of these issues, and really just children being killed, unfortunately, and injured and scared to death and traumatized. Mitch, any thoughts? I know it's pretty close to home there.
Yeah, no, I mean, our son goes to a school with other kids that brothers and sisters go to the same school as well.
Yeah.
It's just a few minutes from our house. It's been brutal. But yeah, it's a senseless act. It's so hard to understand how to even rationalize it. For me, I thought Jacob Frey, the mayor here, said something that was pretty powerful. I
didn't hear that because you probably get better local coverage. So what did he say?
He was saying, don't just say this is about thoughts and prayers right now. These kids were literally praying. It was the first week of school. They were in a church. And I think, hopefully the sentiment of a lot of people in our community for sure. It's going to take something more than just more thoughts and prayers. We really need to. We're failing our kids as a country.
Yeah. I mean, it was less than 2 years ago, maybe a year and a half ago in Nashville, we had a shooting. Pretty similar. I mean, a little bit details different, but came in the school, killed people. We have to figure out a way to stop this. I don't know what it is, but it's. I agree. We need to try to find a better solution. So I wanted to note that. Unfortunately, kind of a rough way to start the show. But Mitch, you and I have worked together in Assort Health for year and a half, maybe.
Yeah.
But maybe give the audience a little bit of your background before Ladder. I know you started at United, or start wherever you want.
Sure.
And then bring us up and give us a little background on Ladder itself, and then we'll jump into the rest of the news.
That sounds great. Well, again, thanks for having me. It's an absolute pleasure. I've spent almost all my career, as you know, Vic, working on populations that are incredibly vulnerable, that have massive challenges around accessing good quality healthcare. It started at United. I was actually on the Optum services side, working on this really complex problem that existed then. It still exists to some extent, but about a quarter of what we were spending in our Medicare kind of senior population were people in the last year of life. And it was just unsustainable. We had very few resources to actually mitigate the sort of disincentives of the current system. Mm-hmm. And so we built a model. I helped build out a care delivery business that was focused on providing doctors, nurses, social workers to go into patients' home and sort of protect them from the hospital. But it really got my passion and interest around really building out and scaling care delivery models, finding ways to protect vulnerable populations.
Yeah. That's still a challenge today. We invested in a company called Affirm Health, doing advanced care planning. There's all kinds of needs in there. There's been a lot of progress made, but we have a lot more to go on that front, I think.
We totally do. Yeah. One of our kind of first publications, the Journal of Palliative Medicine, was what kind of pushed the industry. So it's exciting to see the momentum. But to your point, it's a massive challenge that still exists. But amazing time with United there. I left after 15 years, though. I wanted to get into digital health and really see, because before I left, I was leading a huge population health business for United, working with other payers, United, other employers, and was on this kind of front end of the digital health space where you were seeing some of the challenges of like lack of patient engagement, lack of ROI, how to justify that. I wanted to get into an environment where I felt like you could actually see that work. And I got to know a company actually out of Iceland. These two physician founders, really fascinating, were doing work in digital therapeutics. And the whole aspect of sort of combining consumer grade technology, how do you build stickiness and high engagement but also kind of medical grade software medical device technology that actually has a clinical impact and efficacy for families. And so
Yeah.
we were
And
working
really,
with
Iceland and Europe are probably ahead of us on that front.
way ahead of us. Germany is the only market really today that's still pretty advanced when it comes to prescription digital therapeutics. We had some, if you followed the like Pear and Click and Acolyte, there were failures here.
We had it for a minute, right? Yeah.
Correct. But the structure here is so different. Germany, some of the system they've set up with something called DIGA, has really a ripe environment for that. But our business was also focused on working with pharmaceutical companies, that are the largest in the world, on how do you really drive better adherence, but also big payers here in the States to figure out how do you digitize care management, but also appreciate there's this really fascinating intersection between the work we're doing with pharma and payers of about 50% of chronic care, the reason people aren't adherent is medications. And so if you can solve the medication challenge, you can save significant value there. And we were working, we were actually poaching folks from King in Sweden. That's the developers of Candy Crush. The folks that were finding ways to kind of build addictive habits, but we were using it in good ways to apply to healthcare.
Yeah, you can use that power for good or evil, right? Yeah,
that's exactly it.
Right.
So it was fun. So we were scaling that up internationally. But I was traveling a lot. I mean, my husband and I were in Minneapolis. We've got 2 kids. I've got a 7-year-old and a 1-year-old now.
Yeah.
And we were just on the road. I was on the road way too much.
Running a global business like that is hard. Yeah.
It's a lot. Yeah. So I decided to come back closer to home and wanted to get into upstream and really think about how do you really improve healthcare much, much sooner. And I got to know not only yourself, but some of our other investors that were looking at this pediatric developmental space. It's fascinating. As I got to know it, it's probably the most, I'd argue, overlooked market that exists. There's about 1 in 4 kids in the US right now under the age of 6 that have developmental delays. And of those kids, it's fewer than about 4% of them actually get the clinical care that they need. And it's
so let me just stop and make sure I'm following that and maybe underline it for the audience. So did you say 1 in 4 kids? So
1 in 4.
25%.
25%.
So if I look at a kindergarten class or like maybe at a church or somewhere or Mother's Day out class, there might be 30 kids in there, 20 kids. You have 25%, 5 to 7 that needed developmental support.
That's exactly right.
What does that manifest as? Like what are the symptoms early on? Like what are you solving there?
So like one of the most common things like speech delays. 1 in 6 toddlers have speech delays. You have picky eating is a good, very common one. But you also have things like we work with a lot of hospital systems in the pediatric side who have NICU graduates. Every single of the 300,000 NICU graduates has some level of developmental needs. It could be gross motor related, movement, could be feeding related. All those things need PT, OT, speech.
What percent of babies are in NICU today?
How many percent? I don't know that. It's a good question.
Okay. Yeah.
There's 300,000 NICU discharges a year. So I don't know how you divide that from the total number.
That is, but yeah. Okay, so what is tell the origin story of Ladder. I think that's a good story. Yeah.
Well, so it started with the personal experience. So one of my co-founders, Lizzie, her first child, Noah, was a NICU grad and was dealing with a lot of the complexity that a lot of families face. So as they were discharging, they were, given here's the referral for services you need for Noah. Good luck, essentially.
And call this number or go to this website. Yeah.
Families facing developmental care on average are searching between 4 to 7 providers to even find somebody who accepts their insurance, let alone whether they can get in. Average wait list for her was about average of what it is in this country, about 6 months to get her son in care. Now, she went through the process and gritty and kind of checked around and tried to find other options, but it inspired what inspires us is the wait times on what is today a very broken system, a very antiquated system, are impossible for families. It's around 6 months on average today that most families have to wait to get their kid in. And that's if they get in.
Right. So let's say I have a 3-month-old son who needs support, just got out of the NICU. He's only 3 months old. And now I have to wait 6 months before I start. Right? So that's, I would say that's unacceptable. For a lot of parents, they're not going to be happy with that.
No, and if you know neural development, 90% of the brain is developed by the time a kid hits 6 years old. So it may
you're
not
losing that precious, precious time.
Matter.
Yeah, right.
Totally.
Okay, so did Lizzie? I know the answer to this question, but did she have to invent some new magical solution? What'd she do to try to address this?
So one of the lucky things, so Lizzie was plugged into the Boston Children's family, and what we were able to identify partnering with them was it was a better model. And we really went through the process of building what was the superior quality care of what families who could afford private pay in many cases to be able to go to Boston Children's. We took all that clinical best practice of superior developmental care and took it outside and used what exists today, but has been dramatically forgotten around pediatric care of the technology and AI use cases to really turn into much of a virtual first delivery model. So we're able to take that really effective Boston Children's model and start bringing it at scale to other families.
Yeah, and you came in maybe a year ago, maybe year and a half ago,
Yep.
and your challenge is really take this kind of bespoke, really special thing that was created in Massachusetts, and can you replicate it in other states? Can you bring this across the country? Because it's one thing to build it once in one market, and it's different to start creating a model that you can put everywhere. So maybe talk about what you did in North Carolina and what you learned there.
Absolutely, yeah. So we intentionally decided first to go after fee for service because with 55% of kids in this country on Medicaid, we wanted to make sure we could bring the service to all kids, not just those on a commercial insurance plan.
Yeah.
Because especially knowing this model was virtual first, we didn't have windshield time or brick and mortar costs that a lot of other more capital intensive solutions had. So we could do this really effectively at scale, but we wanted to be able to make sure every kid could get this, especially the kids that were really complex. Because our intention, just like the work we're doing in palliative medicine, was let's continue to publish and show the efficacy of this work in a way that continues to build good momentum around the value of virtual first delivery care in this space. But we started building out what we refer to as these ladder liaisons. These are local representatives that work with pediatricians, because candidly, that's where families go when they've got questions around developmental care. And we help build trust and become sort of the go-to partner with pediatrics when they're looking for options that aren't 6-month wait list or longer. I just got a referral the other day, a kid's on a 2-year wait list to get access to a specialist. So we're able to get these kids in immediately, get them high quality care with some of the best experts and a model that is superior to what they might get in their own backyard.
What was the lead time? Like, what was the market education time in North Carolina? Were you able to get any like academic medical center, analogs to Mass General down there? How did you go about it?
Yeah, absolutely. So we both started with the pediatricians, but then we also started working with some of the leading academic systems in the area. Duke and UNC are two great examples. Partnering with them, they had huge challenges around ongoing developmental care for kids that were discharging from the NICU, different varying levels of what type of support they could provide within the hospital. But as you're seeing across this country, more and more children's hospitals are struggling through financially, especially as you look at some of the Medicaid cuts that are looming. So what they could afford to provide ongoing, as well as families who were driving an hour or two to that hospital for the care that they receive, as they go back home to have an option that didn't require drive times, didn't require taking time off work every week. We actually meet families where they are, allowing us to provide services outside of the 9 to 5 window that most care is provided. About 70% of our care is actually happening in nights and weekends. And it allows us to just help with a lot of these kids who discharge immediately get good quality developmental care right away. And that sort of halo effect, if you will, of working with these large academic systems helps us power more relationships in the community. But fascinatingly, also some of these discharges had pediatricians that we hadn't yet known and can build this sort of interesting feedback loop that allows us to build the business and follow the market.
And then how is the incumbent physical therapist, occupational therapist, how are they reacting to this? Are they resistant? I mean, do they feel like it's are you helping them? Are they excited to come work there? Or are they saying like this is new and different? You're having to teach them. What's the local community of actually caregivers? What's their response been?
It's a mixed reaction. I mean, first, we see a lot of for sale signs up, if you will, because of some of the challenges and both inflation for a lot of these in-person models. So some of the competition is going away. Fewer and fewer are accepting Medicaid. And so if anything, I think there's relief from clinicians to have another option for families who have no other option. But we're also seeing interesting receptivity. Some of the largest players in this space who do physical therapy, for example, have wanted to really reach more of their population, and virtual improves access, but also reduces their wait time, allows some of the PT practices who might have economic challenges to really optimize who's in the facility, as well as 9-month wait lists themselves for a lot of these kids.
Right.
That having a chance to be able to help have an alternative service is something we've been really getting some good traction strategically as well.
Yeah, and then for the therapists themselves, they may be able to see more clients. right? Is
Absolutely.
that right? Yeah. So you
Yeah,
can get paid. They can earn more on ladder, I would think, than the traditional way.
absolutely.
Yeah.
Yeah, and it lets them operate at the top of their license. A lot of models that exist today, you look at like early intervention, these state-run, heavily regulated models, there's a lot of paperwork involved in those
Mhm.
processes. And so we're allowing them to just really operate really as great clinicians, getting these kids the care that they need quickly. We found our providers love both the flexibility, but also the opportunity to really work with kids and not focus so much on documentation.
Yeah. Yeah. Okay. And then just finish with what states you're in now and where you think you'll be in the next year or 2 years, whatever you know.
Sure. Yeah, we're live in North Carolina. We've been scaling up in Massachusetts as well. We'll be launching South Carolina coming up here in the coming months. We're just working through a lot of the insurance coverage work on fee for service. But in the next year, we'll go to another 2 to 3 states. Following year, another 2 to 3 states as well. But on a really good path to get to what is about 100 million ARR in the next 5 years. So healthy state of growth, I think.
Yeah.
But really seeing great traction in the market, excellent receptivity from providers and families around both how bad the need is, but also how effective they're seeing the quality of the care they're receiving. So
Yeah.
super encouraged.
Well, it's great, man. I really like to see, obviously I'm an investor in your business, so I'm completely biased, but I think it's really valuable to be able to deliver higher quality care for the existing Medicaid rates. And now
Yeah.
you might strike other negotiated deals with payers in the future, but Medicaid needs support at the rates that we have today. So it's great to see you helping kids like that.
The reality is that's a population that needs innovation. I think the reality is unless we start innovating, some of these brick and mortar models are going to continue to go up. We have to find virtual first, clinically effective alternatives that are sustainable. And right now, the current system is not sustainable, and you're seeing the impact on that in rural communities, especially across the country right now.
Yeah. Yeah. Well, thanks for the little background. I think it'll be helpful as we go through the stories, people would know kind of where you're coming from more. So let's dig into the stories here. So as you know, we start with the economy always. And so the story here from the Wall Street Journal about how Walmart is winning over shoppers as tariffs are pushing price higher. So Walmart is growing revenue. They're attracting new shoppers. I think because inflation's coming up and prices are more. So what did you think of this story?
Well, I mean, first, you've got what, 2/3 of all Americans go to a Walmart every month. It's just outstanding. And so I think one of the big things that comes to our mind as we see, because we deal with a lot of the families that are here, but like any small impact of inflation, they're feeling it right now.
Yeah.
It's great to see Walmart try to absorb some of these higher prices, but absolutely are we seeing families start having to make hard trade-offs between can I afford groceries or can I take my kid to appointment A, B, or C?
Right. Yeah. And then the next story, also in the Wall Street Journal, stagnant job market is a rising risk for the economy. So, if the prices are coming up, Walmart maybe is gaining share. And at the same time, it's hard to find a job. If you lose your job, it's hard to find one.
Well, I think it's hard now. I worry about what's happening for Medicaid families across this country. You see both looming cuts that are going to likely result in fewer families having access to care. You've got legislation, the recent Affordable Care Act kind of ruling that may impact another 2 million kids on top of that. Like, we're in a very precipitous environment, I think, right now. The risk of inflation, the risk of reigniting some of that inflation worries me for sure. And you're starting to see a lot of hospitals feeling the pressure of that across the country. It's scary for sure.
Yeah, yeah, definitely. So we definitely have this. Marcus and I have been talking about a lot the K-shaped economy, where if you have a lot of financial, maybe more than half your net worth in stocks and bonds and real estate, then in our next story, the Dow lost 300 points, but it's been a record-breaking run. So it came down on the first couple of days of this week. But the thing I wanted to sort of mention is the top part of the K. If you have more than half your assets in stocks and bonds and real estate, you've done well over the last several years. But if you're on that bottom half of the K, where you really rely on your paycheck and not financial assets, and you have a big mortgage or you have a lot of debt, you've been sort of the opposite effect. You haven't got that stock market. You don't have a lot of stock. Stock market doesn't matter that much to you.
Exactly. And that's 80% of this country right now are
Yeah.
on that bottom half of that K curve for sure. They're feeling
Yeah.
it.
Okay. And then the last story, this is more for our Nashville audience. The Boring Company, Marcus and I talked about it here, is, creating a tunnel from downtown Nashville to the airport. It's lots of controversy. Some people love it, some people don't love it. But they have made the next step, and they're negotiating with the airport for an annual license to find a way to kind of come up from their tunnel. So we'll put a link to the show notes if people want to look into it. Let's move into the VC markets. So the first story here, LSAI raised $250 million to fire up healthcare automation, really back offices. What did you think of this deal?
No, I mean, I think for someone who's lived my entire career in healthcare, the reality is there's so much operational waste that can be solved quickly through technology. This is where I think we're from a hype curve perspective, we're really getting to a place where a lot of these administrative functions for AI are having a massive ROI and impact. So it's exciting to see. I think this is one great example, but a couple others in the news this week as well. But huge opportunity to administratively improve. Even us, like as a healthcare company, part of why we built our own EMR in our space was the ability to kind of more rapidly deploy AI type capabilities on this back office side. A lot of patients benefit from the ability to quickly cancel, change an appointment, get a prior authorization done. A lot of the kind of administrative headache stuff can be done, I think, very effectively with technology today. So it's exciting to see traction here.
Yeah, definitely. Pretty big amount of money to raise. They're definitely going to sort of grab a ton of market share, but raising $250 million, a lot of money for what it is, which is automated back office. I don't know how many barriers to entry there are. Although I have some portfolio companies that are trying to do things in particular niches where they have an advantage, I think.
That's what's fascinating too, though. I think that there are a lot of folks running after this environment right now, and so it'll be curious to see kind of which ones have the right differentiated technology and true proprietary technology, and what happens, when some of the big guys, you get your behemoths like Epic, who I think their recent earnings call, their CEO mentioned, I think they've got 200 AI products in the works.
Right.
What happens when they step in? Right.
And the health system can get these AI resources for no charge. They're just sort of included in the fee. That's going to be a challenge. So.
Totally.
Okay. So then we have Wugen, I guess, raised $115 million to bring a CAR T cell therapy. So this is using CAR T for cancer treatment. And they solve some problem, fratricide, which I guess is when the T cells kill their brother T cells. I don't know what fratricide means.
It's like the process today for this cancer therapy, and I'm not an expert, but my understanding, so you take kind of your own set of cells, and that's used over a couple of weeks to develop your own therapy, kind of cell-based therapy. Yeah. That's then re-injected back in the body, and it's a high risk of the cells kind of attacking themselves by using your own kind of your own body cells. The new model that they've pushed, and there's been a lot of really exciting research. I think this is now the second major use case around this whole model, is this idea of like, we're going to build a universal, if you will, kind of donor set that automatically prevents or turns off the reaction of the human body, but could have huge implications of the cost side. I don't know if you've been following some of the costs today on CAR T, but like, I think it's about 10% of cases are well over $1 million per episode. And so
because each one is bespoke, each one uses your own cells. And so this would maybe be more effective, and definitely would be an easier process and less expensive.
Way more cost effective. And I think like in Medicaid, the families we see, if you're on Medicaid, you're 3 times less likely to get CAR T therapy today. And hopefully this opens it up, that allows you to have access to more therapy like this. But this is stuff. What also is scary for me as I think about this and some of the other things in the news, it's like, this was the NIH funded bench science. What's happening, what is going to happen in the future state when we need that next evolution of CAR T, but definitely kind of curious to watch what happens.
We'll talk about, we have a CDC story. We don't really have a other sides of HHS, but obviously NIH has been cutting funding and really cutting the overhead, especially funding. Mm-hmm. I'm hopeful that will be reversed in the future, and maybe I'd like to see a return to investment in R&D I'm fine with cutting the overhead as long as you give, universities and other research labs enough notice. Probably makes sense. But I think the government has to invest in the basic science so that we have the next CAR T, the next thing. And it's not going to be for 10 years, 20 years. But if we stop doing that, we'll stop getting the science out the other side.
Absolutely.
So then the next story, Assort Health. This is in TechCrunch. They raised $50 million automating patient phone calls. And so I have a couple investments in this space too. It's related to else AI, that we just talked about too. It's only one piece of what else does, but it's getting to be a pretty crowded space, it seems like.
For sure. Yeah, I think recent was a Hello Patient just a couple of weeks ago announced another 20 million round as well.
Yeah.
It's every week you see another.
Okay, and then Sleep.ai raised $5.5 million to launch a data-backed sleeping insights. Did you look at this story? What did you think of this?
Yeah, this was one. So I don't know. Part of me, provocatively a bit, is like, when did remote patient monitoring quickly flip as quick as it did into this space of true AI? This feels a bit of AI washing. I think we're seeing some of that across the industry and the concern, but even with 5.5 million, the level of claims that you see, even go to the website, you see things of, kind of true impact on clinical outcomes. I worry some of the level of clinical rigor, even having built software and medical device organizations, what's needed to make sure you've got that clinical rigor to make the claim that they're making here. So I'm curious of I'm excited to see the opportunity to take sleep. I do agree, and as a parent who I saw the impact myself of what sleep does to you, and traveling as much as I did, the impact of sleep on your performance. Absolutely. Do I think we've got to solve this? How quickly and effectively this data translates to physician behavior and different alternative therapies or activities, still I'm up in the air. And so I worry some about how fast we've moved to make the claim around AI personalization in a way that will identify better outcomes.
Yeah, I agree. I mean, that's certainly a risk in this case. I've made a couple investments in sleep. I think sleep's a huge problem, but being able to actually solve it, and certainly the interpretation of what should be allowed to be said in marketing materials or in product materials, and what people are bantering about, throwing AI on it, it's magical pixie dust. I think there's a lot that's going to happen there. But interesting to see. I mean, sleep is a big issue. And so I think good to have more people working on it.
Totally.
Okay, then iBot. I really like iBot. So iBot raised $20 million, Series A. This is a kiosk that goes into a mall that can give people eye tests right there in the mall where they are already. What do you think of this story?
I love these guys. I mean, I think generally the concept of both retail diagnostics, how do you make it simpler? But I think their CEO was saying something in the article of the balance of speed plus clinical oversight, earns trust. I thought that resonated. I think as you move from administrative AI into the true world of clinical, having that human in the middle is so fundamental. I think they've found the right balance. It looks like they're using what is tech that's been around for quite a while to understand how to do these tests. I remember my own experience getting my eyes checked, and it's so much of that you can automate into a simple system like this. And then all you need is a human in the middle to validate the clinical. And if there's a risk, you escalate it. But I think they're doing it right.
And the human in the middle is really valuable for the once in whatever, several hundred times that it's really valuable. But they can also work with lots of these kiosks and lots of patients around the country, I would think, because they're not called on that aggressively that much, but they're there if needed. That's the balance.
Exactly. But at least there's at least a clinician validating every prescription as they're getting sent off. And for that human piece, even though virtually in seconds, if you will.
Yeah, they can do it quickly, but it's the safety check there that I think is valuable. The New York Times, Medicare will require prior approval for certain procedures. So CMS is running a pilot program where they're going to require a pre-auth in order to get treatment. This is fee-for-service Medicare. This is not Medicare Advantage. What do you think of this story?
Yeah, I mean, to me, it's them just moving into privatized medicine to some extent, really getting insurers back in the game, because that's what they'll do is outsource it to insurers to do this administrative work on their behalf. But Medicare Advantage, to your point, commercial insurers, they do this day in and day out. What I liked about it, though, was sort of the front end prioritization towards AI as the premise. So find a way to be able to really leverage technology and AI to fuel how we think about these pilots, which I think is great. But it puts CMS sort of at odds with clinical care providers in a way that they haven't been, which we always know there's that same dynamic between insurers and providers. And so curious to see how this plays out long term. But it does look like and feel like a lot of what we've seen in Medicare Advantage and other insurers for sure.
One of the experts in here talks about a backdoor to privatization of Medicare, because it's not literally privatizing it, but you're sort of introducing this control or a constraint mechanism. I mean, I think it's a spectrum, right? You could have the pre-auth approval process be very broad and everything gets approved, and that won't really reduce costs at all. Or you can try to really drive some savings, but you're going to, I think by definition, limit access to care.
Exactly. Yeah, and you've got a lot of lawsuits on the Medicare Advantage side, for example, around accessing care and premature denials like that. So it's like, what is this going to look like long term when you exacerbate that, and what's the impact on patients going to be? That's what I'm curious of too. We're seeing the delay on families because of the intensification of some of these prior auth hoops that people have to jump through. So as you expand this to more, is that going to make it worse?
Yeah. So now we're going to talk about the CDC Director Susan Monarez. Hopefully I'm saying that right. So this is an interesting story. She was installed as a CDC director about a month ago. I mean, so she got named several months ago, but it takes a while to go through the confirmation process. She was confirmed. She got fired this week, and I believe it's reported here because she was in conflict with Secretary Kennedy about the vaccine policy. But then we have a couple stories, and we'll link to all of these in the show notes. So Fierce Healthcare ran a story, pretty, I think, straight down the middle, sort of just describing what happened. But then the New York Times has a story saying that she's not agreeing that she can be fired by Kennedy. And then they introduced the concept that there was a meeting on Monday where this director, Susan Monarez, was going to talk about vaccines, but that's not going to happen anymore because she's been fired. What are your thoughts about this?
Yeah, we don't know exactly what they're going to talk about then, but what was clear in parallel, the American Academy of Peds came out with a pretty direct statement that went both to kind of broader populations, but directly to payers as well, to start positioning themselves as an alternative source that's evidence-based when it comes to vaccines, because they directly disagreed with the recent changes in vaccination in kids. And you can see, and I know it wasn't just Susan that got impacted, a bunch of folks there.
But several people have resigned.
Yeah,
several top people have resigned, like the heads of various groups there.
Yeah. We've got to find a way to rationalize these two. I think the big thing that worries me most is families are going to be so confused. And pediatricians as well. Now you're going to have insurers deciding, do I cite, the federal government? Do I cite AAP guidance to make my decisions? How do I really decide what's clinically the best practice care? Physicians are going to get confused, families are going to get confused, and kids are going to get stuck in the middle. You're already seeing with measles, numbers of deaths have skyrocketed since essentially it was eliminated in 2000. So it's scary to me to see how we can't, as a country, just have the conversation to figure out how do we get the experts together to agree on a stance here. But these two powerful pediatric groups not aligning was definitely a sign.
Yeah, and I mean, I sort of am two minds of this. Like there has to be a chain of command control. Like so in the executive branch, president down through the cabinet to the various administrative bodies, and CDC's in that org structure. And yet there needs to be sort of space for science to be done sort of outside of politics. Where we draw that line, it's hard to say, right? Like in for-profit private companies, there's clearly like you go work there and you report to your manager and on up to the board of directors and then the shareholders. And then in scientific journals, it should be just sort of, you have a hypothesis and you're running tests and collecting information, and then you try to just look at the results. It's kind of interesting just to see where this is going to come down, but there's definitely lots of loss of credibility on all sides. I mean, it started with the pandemic and it's getting less and less credible. The entire American administrative establishment is losing credibility by the day, it seems like.
Totally. Yeah, I agree. It's scary.
So anyway, sad story. I don't know how it's going to end, but it's going on right now. But the Monday, 2 days after this drops for publication is when she was supposed to give whatever she was going to give. Okay, so finishing the policy and moving into health systems, solution in search for a problem. This is in modern healthcare. The American Hospital Association, AHA, slammed the 340B rebate pilot. So, at some level, of course they did. They represent a bunch of health systems. But they are pointing out that the 340B program is relied on by a lot of health systems, and it's really not going to be possible for those health systems to continue forward if this pilot were to go across the country. I don't know. What are your thoughts about this story, Mitch?
Yeah, I mean, this is to your point. One area that worries me is rural hospitals in particular, but hospital systems across the country rely on this sort of upfront rebate model to justify access to care, to medications, to other types of care for families, especially low income and Medicaid families across this country. And so I think that forcing them to rebate, to sort of float the funding up front and then collect later, that timing issue when margins are thin, getting thinner, especially in rural hospital systems, is going to probably put more pressure. So I think of the fact that what this is going to have on families too.
I think that's right. It's very similar to the supplemental payments in Medicaid. I mean, like I don't know that I can defend the 340B program as really that logical, but it has been going on for a long time, and health systems rely on the money, and they have significant infrastructure expenses and people expenses that you can't change that quickly. And so all that is sort of what we're wrestling with, I think.
Totally. At the same time, we also know we have a spend problem that we've got to solve as well. And so
Right.
The positive is they're signaling, hey, let's pilot, let's test. And so hopefully that's coming at a place of curiosity. But the hope would be these groups come together and solve both the financial challenges facing both sides and come together on solutions how you solve that without putting patients in the middle.
Yeah, definitely. Okay, so moving into payers now. In Bloomberg this week, UnitedHealth ongoing criminal probe is broader than Medicare. And so the DOJ is also scrutinizing OptumRx. And United is, they're cooperating. They're trying to get to the bottom of everything. You're in Minnesota. You used to work at United. You have family and friends that are there now. I don't know what your thoughts are, or you won't even get into this. But I mean, I think if you look into any large company of United's size, if you look carefully enough, you can find something. I don't agree with the criminal side. So, there might be something that was done. There's a lot of health systems and payers that have all kinds of questions around how they bill, how they do things, how the criminal would mean that it is like forethought, intent, there's knowing that's going on. And I'm not sure about that. What are your thoughts of the story, if you want to comment on it at all, because it's close to home?
Yeah, no, it's close to home. But at the same time, I think this is like the vertical integration strategy of United. It's one of the big challenges, to your point, that they face. They've got their hands in all parts of healthcare. And part of it with the intention of really helping improve access for families and more affordable care. But as you get really good at playing the game within these different businesses, and the government sets these businesses up and allows the regulatory within them, it's very easy to be able to figure out how do you optimize within this space. So I don't know. I agree with you. I don't know if I understand the criminality effect. I think I hear and you see in the news this current administration going after pharmacy benefit managers specifically and kind of targeting them as something that is limiting price transparency, that's driving up costs, that this is unnecessary middlemen. I don't know where that positions, but clearly the timing of that push and this DOJ is interesting, intriguing at least. But yeah, I don't know. United's just had a rough year with BT, Brian Thompson, with everything going on with broader DOJ cases. It's an easy target to hit them while they're down, but I'm hoping for these guys to rally back for sure.
Yeah, I think they've, some of the most talented people I know work there, or have gone through there. And I think that the entire question of should a regulated insurance company also employ the most doctors of anyone in the country on an unregulated basis? I mean, that's a question about what DOJ, should that be together in the same company or not? but that's not what they're looking into. They're sort of just digging into particular silos. And I think there's a broader story that, United has done everything right as far as creating Optum, which is, just really great work in delivering care and is also very profitable. That's sort of what you're supposed to do. So I don't know. I think it's going to be a hard couple years for United. And if DOJ looks carefully enough at anything, they can find someone, whether it's intentional, criminal things. I'm not sure about that.
Yeah. And the model they've created, to your point, is something everyone's replicating. You look at the Caroline
Right.
at Elevance, it's identical. You look at
Yeah.
what Humana's
Yeah.
doing.
Cigna and Evernorth. I mean, yes. The fact that they did it bigger and better than anyone else maybe should be applauded more than criticized. But
Exactly.
And then Johns Hopkins is leaving the UnitedHealth network over contract disputes. You and I were talking before we hit record, and we were saying that this happens every year. Someone is debating, but this quote caught my attention here that United is saying one of the issues is that Johns Hopkins is demanding the right to refuse treatment to subsegments of their population if they don't like an employer. And I hadn't seen that before. Now, it may just be that United is trying to spin a story. We don't know the details, but have you seen this kind of topic before?
No, this caught me off guard for sure, to your point. Like, I'm so used to the normal back and forth rate negotiation process. I think that's almost what you saw before. Now with inflation, cost escalation, I'm not surprised to see more payers get back into this old muscle memory. But this idea of the opportunity to refuse selective treatment to different cohorts, that caught me way off guard. It's curious. I don't know all the details and intention behind it, but definitely this could be a slippery slope for sure.
Yeah, I think that is going to be something just to watch. So we'll see. Okay, and then this next story is in Healthcare Dive. No surprises, dispute resolution is creating billions of dollars in extra costs and could raise premiums. And so this analysis was done. Healthcare Dive is publicizing it. What I wanted to get your thoughts on is, there's a lot of infrastructure expenses just keeping track of this and fighting over it. And, are we actually saving any money here or not?
No, I mean, that's what the clear statement seems to be, right? It's like $2.5 billion each year in administrative expense. It can't justify the intent behind this. Like, this was generally a well-intended consumer protection function, but it was not thought through in terms of how do you operationalize this at scale and appreciate, like a lot of us know that are in healthcare, that there's a lot of wonky operational processes to actually follow through on what they're intending to accomplish in this. You saw the hyper focus on, there were 43% of claims that were tied in one of the years to private equity backed organizations. Like what that was curious for sure.
Yeah. Well, I mean, I think that there's implications of, why are private equity backed organizations pursuing this more? And it could be that they had taken advantage before the No Surprises Act, or it could be that they are very focused at rigging all the revenue cycle collections they can, or something else I can't think of. But yeah, definitely it's a lot of private equity money behind it.
Yeah, for sure.
Okay, and then out in LA, this is in KTLA, which is a TV channel out there, I think. Hundreds of LA children hospital employees got laid off at LA Children's Hospital. You're involved in kids treatment. This was a sad story. People, 439 people were laid off, about 6%.
Yeah. This is hard. I mean, I think I've got coworkers that work in some of the largest systems. I've got an advisor that's out in California at one of the leading pediatric centers there. And they're facing, I think she was saying, 180 million cuts this year, another 250 next. It's just, I think this is unfortunately the reality of what a lot of these systems face. Pediatric healthcare in these large systems are expensive on a per patient basis. And so it's terribly sad to see. It's another reason why we've got to keep pushing to see where can we find ways to drive innovation to occur in pediatrics. Peds have been forgotten. Venture capital has less than somewhere between 0.2 and 2% of venture funding has gone to PEDS use cases. Mm-hmm. Now is the time to start putting investments in good quality clinical models. Absolutely, like you were saying before, we were talking through the news on administrative items, but I do think PEDS is a ripe space to continue to focus on investment as well, because the more we can build cost-effective alternative delivery models, you can build a more sustainable support system for these kids for sure.
Yeah, definitely. Okay, and then Corewell did a joint venture with Quest. This was kind of interesting. They basically sold Quest all of their lab infrastructure, and then they're going to offer it to the whole region there. I thought it was a smart thing. As hospitals are trying to look for more cash flow and less complexity, they probably need to do more deals like this, really.
Yeah, I think you're going to see more focus on the core of what you can do well around patient care, outsourcing this sort of like commodity type service, especially something that as we think through the earlier instances of AI opportunity to really optimize this, may not be a core competency of what a health system wants to focus on. But if they can find a way to do it and profitably capitalize on that, seems like a smart move.
Yeah. Okay. And then Walgreens finished their going private process today, I think, or yesterday. I think it was today. And they have split up the business into 5 different pieces. So Walgreens, kind of the retail clinics, the Boots Group, which is really the European aspects of it, Shields Health, CareCentric, and Village MD. What did you think of this story?
Yeah, mom and dad should never have been married. I mean, I think this was a long, drawn out, divorce process that a lot of us saw coming that knew the industry. Pharmacy is so like transactional based. Risk-based care delivery models are still relationship driven. They tried to smash together the two of those kind of really different animals, and you just knew this was challenging from the beginning. At least some of us did.
Yeah.
So it didn't surprise me to see it. Surprised me it took this long to get it through, especially knowing Sycamore's intention and kind of focus and where they're great at. And so I'd be excited to see kind of what this next chapter looks like as they lean in.
Yeah, I agree. Okay, moving to pharma. Novo Nordisk is freezing hiring in non-critical areas. This was, I think, pretty surprising. And then we had the next story. Eli Lilly eyes their GLP-1 pill form after phase 3 diabetes trial success. What do you think of these 2 pharmaceutical stories?
Well, one, I've been rooting for better results on the kind of oral option for GLP-1s for sure. I think we know the challenges for families on injections as well as just access and cost side. This is a huge win to be able to hopefully see a really accessible alternative. I think the other side of the story, though, to your point, is you're seeing how capital intensive healthcare is, even for the big giants. The fact that they're having to cut, it worries you. So everyone is tightening belts, even these guys. So, you've got your golden child, if you will, with what's going on at Novo, but internationally, it's putting pressure on everyone.
Yeah, definitely. I mean, all of healthcare, like stocks have been down. Everything is sort of we're in transition, at least. So, okay, moving into Web3, Peter Thiel is leading a pack of investors piling into Ether. This is in the Wall Street Journal. They're talking about Ethereum and how Peter Thiel and a whole bunch of other investors really think that Ethereum is going to be the real growth engine. So part of this is just to sort of educate the audience around, we have Bitcoin, which is probably the oldest store of value, but Ethereum is probably the best well-known, like for more actually processing and doing activities and running applications on top of cryptocurrency. Mitch, what do you think of this?
Oh God, this is an area I'm so far ahead of my skis. Yeah, I don't have a strong opinion for sure. I'm learning with the rest of your listeners for sure.
Okay, then the next story, we have the next 2 stories are about global stablecoin payments. And so Circle, which we've been talking about here on the show, they have a stablecoin USDC, which is it's a crypto coin that is always fixed at $1. So you can pay for healthcare things, and you don't have to worry about pricing in some other currency. It's in dollars, but settlement is much cheaper, faster, and more secure. And so Circle has now partnered with MasterCard and Finstra. MasterCard, of course, everyone knows here in the US, but Finstra is actually, I think, might be even bigger globally as far as a payment processing kind of network. And so they'll be connected to Circle. And I think we're going to start seeing, like, on your credit card, you might be buying things in USDC as opposed to USD because it might cost you a 3% transaction fee to buy something in Africa if you use your MasterCard and want to do it in dollars, but no charge if you want to do it in USDC. And so I think that's where we're headed, that it will be a lot of transactions, just much cheaper transaction processing. And then the next story is in the Merkle, which is a focused kind of Web3 publication. But Google Cloud has created sort of a new competitor to the stablecoins just for processing transactions. And they're literally going to do a cross-border so that they can reduce the cost of like the Swift network or wiring money back and forth. And so we're tracking this because there's a lot of payment processing, revenue cycle management, tracking of transactions in healthcare. We spend way too high a percentage on that in healthcare. And I think we can kind of jump to some of these Web3 solutions, whether they're some cryptocurrency or not, as long as they are more reliable and faster and less expensive, I think it could really be helpful for healthcare.
But the other thing I'm curious of too in this space, and I don't know the answer, and clearly not enough of an expert, but like the debate we've had for years around how can we get to like single health records that we can bring with us. What's fascinating is also you hear about the concept of tokenization, similar mindset and mentality for health records as well. I'd be curious to follow this along too to see if that reemerges as a key theme in this population as well.
I think it definitely will. I mean, the blockchain is the place where you would have a sovereign health record. Like I own my DNA is my, it's my IP. It's my literally what makes me. And then I have a bunch of health transactions, procedures. I was born. I had A, B, C things happen. I'm 55 years old, so I had a lot of stuff happen. That should be in my personal health record, and it's it should be encrypted on a blockchain, and then I can share it with doctors or whoever as needed. I think that's coming in the next 5 years, but it's not quite here yet. We need a way to pay for it, right? Okay, moving into AI. The first story: CoinBase CEO explains why he fired engineers who didn't try AI immediately. So Brian Armstrong is the CEO of Coinbase. He gave his tech team a week to kind of onboard AI tools. And then, at least in the story, it claims that on Saturday, he had a meeting with anyone who didn't try it out. And a few people were on vacation or sick or had something going on. But a few people just said they didn't like it or didn't want to. And he fired those few people on the spot, which, I don't know, it definitely sent a message. What are your thoughts about it, Mitch?
I think the message of like AI is not optional is a strong message. I don't love the way the guy went through about it. Not the culture I would create or but I do think like finding the right incentives. Maybe there's carrots and sticks to go after it to be able to help. Which it does sound like even after they concluded they were focusing more on investing than on education and how to optimize the use of AI. But for us, for sure, we're embracing it every day. I think you have to be if you're in healthcare right now or any business, to be honest. And not embracing AI is just stupid.
Yeah. So then in the Wall Street Journal, Nvidia predicts cooler growth. So they had their earnings. The data center revenue, which is the biggest growth engine, did not fail to meet expectations. So the stock's been down about 2%-ish today. They reported yesterday. But we were talking before the show. I mean, you can see if you're watching on video, the revenue is this quarterly revenue. It's been growing, I don't know, maybe 200 million a quarter in growth, quarter over quarter. So pretty almost a straight line up. A couple of years ago, they were at a 10 billion, 8 billion a quarter kind of run rate. And now they're in the 40s, 47 billion last quarter. So growth is slowing. Jensen Huang, of course, spoke, and he said he expects the largest AI companies will spend 3 to 4 trillion in the next 5 years on AI infrastructure, and that Nvidia should be able to get 70% of that amount, which is just an incredible market share on an incredible amount of spend. 3 to 4 trillion is a lot of money. I don't know. What do you think of this story?
Yeah, I mean, I think some of this is partially what the maturing of the market, if you will, and some of the normalization of the AI hype after such explosive growth. But the other caveat is this is all pre-China, right? Like they just are granted the ability to start selling and expanding pretty aggressively there. So I'm curious to see
Yeah.
like how that compounds this further. But it was funny when the other article I'm watching, Jensen this week was him out in China as they got the approval out there signing jackets with like gold colored
Oh, yeah.
stuff. And
Yeah, he's a rock star.
Yeah.
Yeah, that's right. Okay, then next story is in Bloomberg. Apple explores using Google Gemini AI to power a revamped Siri. Of course, Siri needs help, and I think Google Gemini would be a good choice. What do you think of this story?
Yeah, it doesn't surprise me. So as we know, under the covers, Google is already powering their search function. It's the standard browser, default browser, if you will, for all search on Apple. So it didn't surprise me at all. Who they're looking at. What's interesting and more worrisome is like there's an active DOJ case going on around.
Yeah,
is this even possible?
Yeah, actually, by the end of August, they're supposed to decide whether the Apple Google kind of search embedded in iPhones is allowed. I think Apple makes, I don't know, 20-25 billion a year on
it was 20 and I think 22 or something 20. Like that. It's been growing for sure.
Yeah, so that might end in the next little while. But yeah, so they have a tight relationship with Google already. I think that makes sense.
Yeah. But who else would they go with? That's the curiosity. It's like would it be ChatGPT?
Well, I mean, right now they have a relationship with ChatGPT, but it's not embedded in Siri. It just is in the Apple intelligence thing.
Well, what does it say though also to the employees at Apple as well of like their commitment around AI overall? These core functions are, being outsourced, if you will.
Yeah. Yeah, that's right. I mean, well, they're so far behind. It's not normal for Apple to outsource software, but they're way behind on this. So I don't know. I think they might have to for a while. Okay, then just a public service announcement. I have Gmail. Google, this is in Phone Arena, tells all 2.5 billion Gmail users to change your password. So Google got hacked. I think many of their passwords were stolen. I changed both my passwords this morning. I recommend you change it. So not much more to say unless you have a comment, Mitch. But this is in AI because AI is empowering more and more of these threats.
Totally. Yeah. Don't click links was the big takeaway. And it surprised me when they said 64% of people don't change their passwords regularly. That's scary.
Yeah.
For sure.
Well, yeah. I mean, I have a password manager. Before I had that, it was much harder. I don't know how people do it. Okay, next story. In the Wall Street Journal, Perplexity is launching a new revenue share model for publishers. So Perplexity is an AI company. They have sort of tried to recreate the browser search experience for AI. And now they have this new revenue share model where 80% will be shared with publishers. We need a business model in AI so that we have some incentive for people to keep making content. I don't know. What do you think of this, Mitch?
When you look at the math of the 80%, that I don't know if this is the model. I agree with you. I think we've got to figure out an alternative from the current ad-based structure. But what I'd love, because I don't know with 80%, can you still afford the type of investment you need in the AI to pursue the quality and the resources and how you're displaying it? So it piqued my interest to see an 80% revenue share of whether that's sustainable. But at the same time, agree with you fully. Like I think we've got to find alternative models. So it's great to see them testing out the waters.
Yeah, I agree. I don't think it's the final model, but good to see them trying it. Okay, and then Anthropic settled their big AI copyright suit. Mitch, a couple of weeks ago, there was the judge ruled in favor of Anthropic that to the extent they had acquired, this is against authors sued Anthropic for stealing their books, putting it into the AI. The judge agreed with Anthropic that if they acquired the books legally, they could then put them in as training and use that information as part of their product. And that was a fair use. So they kind of won that case. But then he pushed to a jury trial the question of, did they acquire the books properly or not? And I think the answer is some yes, some no. And they settled because the estimate was if they lost, it was going to be up to 900 billion in damages. And it was, I think, literally like an out of business legal risk that they just couldn't accept. So the numbers are just incredibly large.
Absolutely. Yeah. It's crazy.
Okay. And then in the New York Times, he sold his likeness. Now his avatar is shilling supplements on TikTok. So this is an actor, and his name's Scott Jockman. He's an actor, so he was paid $750 to do a spot for TikTok. They flew him to San Francisco. They recorded him doing this voiceover kind of video thing. And then for a year, TikTok had the right to use his image, likeness, everything. And they have turned it into an avatar, and it's selling all kinds of stuff. We'll put a link in the show notes. You can watch all the different ads. What do you think about this? It's pretty scary to see like how many times he had been replicated. He's speaking different languages. It's a little bit crazy.
Yeah, it was crazy how effective the visuals really are and how advanced AI has gotten.
Yeah.
But at the same time, it's like probably should have taken more than $750. And beware of what you're signing up for. The risk of being used for things you may not endorse or want to endorse is pretty scary for sure.
Yeah. Okay, then we're going to end on, unfortunately, kind of a hard story, but I think it's an important story in healthcare and AI. So in the New York Times, a teen was suicidal, period. ChatGPT was the friend he confided in. And unfortunately, he ended up committing suicide. And his father had no idea that he was chatting with ChatGPT, but just going through his phone trying to find answers, and found all of the text messages and chats back and forth for about the last year. This is a 16-year-old boy. What I wanted to talk with you, Mitch, about is there were multiple times when he asked the chatbot for advice about how to commit suicide, methods, techniques, how he might draft a note, how he might put together the rope for a noose. These were not subtle hints that the technology would need to parse through. Now, to be fair, they talked about lots of other stuff for hours and hours and hours. So certainly it was in and amongst a lot of other content. But I think the family has a right to say, like, this is a minor and technology should have some guardrails. When you're asking for advice on how to commit suicide, there's not a more clear signal than that, I don't think.
Absolutely. No, it's scary at the least. The kid was in there to do homework to start. And through building trust through the chat, it got him to a place to self-disclose. That's the point when a normal human would take a different set of action. But because it's a machine, it didn't have the same governor a lot of us do to realize something's off. We should look for help. And so it's scary. I mean, it reinforces, as we think about the use of AI, especially in like clinical care, mental health care, anything, having some aspect of human in the middle or figure out the right guardrails for safety and the risk is just fundamental. This is so depressing to see.
Yeah, there's no question. And so this was in 404 media. It needs to be covered more. I wanted to bring it up. So 44 attorneys generals around the country. So 44 states signed a kind of an open letter to 9 AI and social media companies, all the big companies, Anthropic, Apple, Chai AI, OpenAI, Character, Perplexity, Google, basically anyone they could find that is in this space, and really kind of saying to them, we are going to, we as attorneys generals are going to hold you responsible for doing wrong to children. And they specifically kind of carved out minors. And so the quote that I wanted to get your thoughts on is, it is unacceptable to engage a child in conversations that are romantic or sensual. Your innovations are changing the world and ushering in an era of technological acceleration that promises prosperity undreamt on by our forebears. We need you to succeed, but we also need you to succeed without sacrificing the well-being of our kids in the process. Exposing children to sexualized content is indefensible, and conduct would be unlawful, even criminal if done by humans, is not excusable because it's done by a machine. This was from blue states, red states, just 44 of our states. And I think it's really important. And I put it related to the New York Times, although that, of course, was a suicide. I think that our political infrastructure, our government infrastructure has to step up and protect at least the minors amongst us. Maybe adults are different. I mean, I think you could argue that. I don't know if I would or not. But for children, certainly, we need protections.
Totally. I mean, you think of where we started today and just what happened in my backyard. There massive need as a society to figure out how do we help people when they're asking for help. I think technology innovation has to play a role, and I think we can lead through technology to set better guardrails, better safety systems. But I think I was proud to see these AGs step up the way they are. I hope the action and reaction is as forceful and as direct, but absolutely as a parent of 2 kids, I think we owe our kids more. We can't keep having kids having suicide. We can't keep having mass shootings to kids jumping under pews at churches in our own backyard. We've got to do something better. And I hope technology leads the way to help us solve some of them.
Yeah, I agree. And then just to close it, OpenAI did respond that they're updating their systems to try to not have the same thing happen again. I think that's fine, but a little late. Certainly a little late for the child that committed suicide. But I guess better late than never, maybe. So
I don't know. I mean, we work in childhood development. This whole idea of like wait and see is what's compounded the system to be what it is. I think you put the type of money we put into these resources, you've got to learn how to proactively think about what are the risks and challenge the technology you're building. And I think you look back and you look at Meta and some of the stories from Mark and team of what they've said. It's like, well, maybe we wouldn't have thought of the like button in the same way. Like, think through proactively some of the implications on your design, proactively in a way, and put parents first, put kids first, put humans first as you're designing. I think there's so much we can learn from that.
Yeah, I agree. And so it's great the work you're doing at Ladder. I think we have some work to do in managing our AI tools, but hopefully the states are beginning to wake up and maybe take some control back and just put in reasonable guardrails. I mean, the AGs are not saying we don't want you to win. They literally say they want U.S. companies to succeed, but we need to protect our kids at the same time.
Those should not have to be diametrically opposed objectives.
Yeah.
You can do both.
Right. Exactly. Well, okay, Mitch, thanks for doing this. Really appreciate it. It's great show. Marcus has to watch out for his job.
It was an absolute pleasure, Vic. Thanks so much for